Okay, now what about if norepinephrine were binding to cardiac muscle, which can happen? Now in that case, it's going to bind to an adrenergic receptor called a beta 1 adrenergic receptor. And it opens calcium channels in the heart. This increases the frequency of beats. In other words, it increases heart rate and increases the strength or the force of contraction. We call that contractility. Increase contractility. Okay, so next question then. If a patient, let's use a different pen, how about a black pen? If a patient had their heart going too fast or was working too hard from maybe hypertension or they were in congestive heart failure, which kind of receptors would you want to block if you had a drug to do so? Would you want to block the muscarinic cholinergic receptors, or would you want to block the beta 1 adrenergic receptors? Well, I hope that you would want to administer a beta blocker over a muscarinic. So beta blocker will decrease heart rate and contractility. So the goal, if the goal is to let the heart rest a little bit more, it can be achieved. Fortunately, if someone has to take beta blockers, it might also mean that then their heart is not able to go as fast as it needs to if the person wanted to exercise. So their lifestyle is limited if they are on beta blockers, possibly. Okay, now what about the opposite situation? If the patient's heart was going too slow and they wanted to speed it up, then they could administer something like atropine, which is a muscarinic cholinergic receptor. The problem is there can be side effects. There are other places, many other places, that have muscarinic cholinergic receptors, so the drug needs to be specific enough to the receptors that are found in the heart that it doesn't cause massive upheaval in body function. Beta blockers are fairly specific to the beta 1 adrenergic receptors that are found on the heart muscle.